Thank you. I'm sure Kenny Rogers, a Texan, would appreciate the New York take on his song here. So our next speaker, continuing the New York theme, is Dr. Michael Smith, the Chief of Gastroenterology and Hepatology at Mount Sinai West and Mount Sinai St. Luke's, and Associate Professor at the ICANN Mount Sinai School of Medicine. His talk is going to be about what to do after complete BE eradication or not. Dr. Smith?
Thanks, Hashem. Thanks, Trip. Great to be here. Thanks to everyone for making this meeting such a special event. I'm really thrilled to be a part of it, and I hope to continue to move the ball forward here as we continue through the course. Here are my first set of disclosures. Here are my second set of disclosures. First of all, I'd like to correct the record. I did not go to Bible study with Felice. I went to summer camp with Felice. Though actually, having heard her talk, this is going to feel like a revival because I'm going to give some hallelujahs to some things that Felice just said. So it may be Bible study at the end of the day today. I've also never left a dog unattended in an elevator, nor have I left one hanging from a leash, and I just wanted to make sure that that was stated for the record. My third set of disclosures, this is the first lecture I think I've written ever where I had the goal of asking more questions than answering questions. And I think that that is really a hallmark of what we're trying to build with AFS, and that we want to bring the questions out there, and we want to bring the smartest people who have the most expertise in the area of foregut disease to come together and answer them collaboratively. And so I'm really thrilled to do that, and I hope that my asking questions will get people thinking, and then we'll have enough time, hopefully, before we run up for lunch for the Q&A session. I really do think this is a great thing that we're putting together. And then thanks, Felice. I'm not really clear about the subject of the talk. The title that you gave me, I kind of felt like I didn't know where to put the emphasis, and when I changed the words around a little bit, it gave me 18 different talks to write, which is probably why it was so difficult to finish writing it. So I'm going to take two of those 18 approaches. The first is, what do you do if you don't get to complete eradication of intestinal metaplasia? And I'm going to use CRIM and CEIM basically interchangeably. And then the second is, what do you do when you get there, or not do? All right, so let's talk about getting to complete remission of and eradication of Barrett's esophagus. So I think Felice really set the stage beautifully with this. You really have to pick the appropriate and effective eradication device and method for each patient. Right? The technique that you select needs to match the configuration and the topography of the Barrett segment that you're planning to treat. You have to pick a device that's being used correctly by the endoscopist. I think you heard about the high volume centers and understanding your limitations. That's so important. And that repeat treatments are performed in a timely manner. You're not giving the disease a chance to come fighting back in a rope-a-dope-like fashion. And, you know, as Felice also said, adequate suppression of gastroesophageal reflux during the procedure, and I would actually expand that beyond acid reflux to just say reflux in general, is so important to achieving CRIM. So we talked about the workhorse, the radiofrequency ablation, and it's amazing to me that this May will mark 10 years since AIM dysplasia was conveniently published the week of DDW. I've still not quite figured out who at Barrack slipped a couple of, very nice bills that people are winning in the casino underneath to get that timing to work out. But RFA really has become the ablation workhorse, and if you think back a decade, it wasn't. It was not available really in most places, and insurance companies were denying it left and right, and we've come a long way, baby, from where we were back then. And how does it work? As it was discussed, it's a bipolar array of electrodes that generates an electrical field. It basically, it's like cooking a hot dog in a microwave. It boils the intracellular water, and the unstable cells die off. And then in the setting of suppression of reflux, the neosquamous epithelium regenerates, right? And this is so much better than the other ablative techniques we've used in the past because it really controlled the dosimetry. We were able to get a set amount of power and energy out there, and that allowed us to be able to treat to a specific depth. And that's really what the goal is, right? It's again, I'm going to borrow what we heard earlier. It's the Goldilocks concept, right? You want to treat deep enough that you get all the Barretts and not too deep that you get the muscle or into the adventitia and create a perforation. And why might RFA not eradicate all Barrett's? We saw the data, the numbers are great, and what's amazing to me is if you go back and look at those numbers and realize how incredibly inexperienced the users were that generated the numbers in AIM dysplasia, and now what they would do if we repeated the study with the same people, having had hundreds and thousands of more cases, what numbers we could get. But there are a number of factors that we have to think about when RFA isn't doing the job, right? And let's see if we can work through those briefly here. There's a defined extent of the electrical field that's generated during ablation, and if the depth of that field does not penetrate all the way down into the esophageal wall to the lowest, deepest layer of Barrett's cells, then there's Barrett's that could be left, right? And what determines the depth of that energy that's delivered? Well, the device, right? Your power settings. Some people have the ability to adjust those, some do not. The proximity of the probe and electrodes to the surface of the intestinal metaplasia, and the presence of things sitting on top of that mucosal layer, blood, mucus, other stuff that's in there, food that's been refluxed, that could get in the way in between the probe and act like a resistor that swallows up the energy and doesn't let it get delivered to the cells. And an uneven surface, so that there are some spots where the device is sitting right next to the mucosa and delivering all the energy, and other areas where there's a gap and that energy is being wasted. So why is this important? Well, it gives us a risk of untreated, or I would argue undertreated, Barrett's esophagus, right? RFA technique requires that each treatment site receives multiple treatments during the same endoscopy. It's not a one and done for each site. We hit RFA up to 4 times per site per endoscopy. And any change in the positioning of the probes between ablations, especially with the focal device, increases the likelihood that a particular location is not going to get the full treatment that we want it to get, so that we get that treatment extent all the way down through the Barrett's layer. And the lack of precision in probe placement thereby raises the potential for an undertreated or even untreated skip area in between the treated sites, either at the surface or potentially deeper down, and we'll talk more about that. Now, the use of the circumferential probe certainly helps, but it doesn't eliminate the risk, especially, for example, in our patients who have a very large, dilated esophagus, where we're suctioning down, we're bringing that esophageal wall as close as we can to the probe, but it's still not making full contact. So how can we maximize our chance of RFA getting us to CRIM? Well, we could certainly do a detailed visual examination of the segment first. You heard about that from Sri and from Felice, how important that is to make sure that we don't miss any nodularity. And obviously we know that RFA should not be used to treat nodular disease, and so we should be switching to EMR or, again, other techniques to see how deep that lesion is. And we really need to be honest with ourselves. If we don't think RFA is the right lesion, but it's what you have in your toolkit, don't force it on a patient when you're not sure that it's the perfect fit. You want it to be the perfect fit. You want to get every patient to CRIM every time. And if it's not looking good, abort. Walk away, run. I sang with Felice, and we'll be doing some karaoke together later. But, know when to walk away and know when to run. Please, please, please with these, because you don't want to screw this up for the patient. It could be life and death for them. I like to use a mucosal cleaning technique. I use N-acetylcysteine on every patient before I do the ablation. And in fact, I save half of the 60 cc's for right before I do the second round of ablation as a way of making sure that I get things nice and clean. I also have the anesthesiologist give 0.2 of glycopyrrolate for every patient to dry up the secretions and minimize that gooey stuff that sits between the probe and the mucosa. And the last one really is, I'm kind of a bully pulpit thing for me, and now I'm up here, I guess I can use it. Avoid undersized devices for the job at hand. Please don't use the focal 60 probe to do the EG junction. It's not wide enough to flatten out the gastric folds and get a really good treatment. Use it in emergency situations. Use it when you got to get around a stricture. It's not meant to run the EG junction, which we all should be doing because it's the hotbed for recurrence and residual disease. And you shouldn't be using it for that. And think about when you have a long segment, 3 centimeters or greater, think about using the balloon. I know it's easier to pull the probe out and it's cheaper, but the fact is that those skip areas that you can get can really cause damage and problems for the patient later on. So think seriously about using that, especially now it's so easy with the self-sizing balloon. It's a much faster procedure, and it's much more PhD, right? Press here, dummy. Okay, so he's not here, and his friends from Rochester, New York, who are here, please don't let this get to his head so that he can't walk through the doors in your hospital. But Vivek Kaul made a very brilliant statement a couple years ago that I heard, and I want to quote him. And then he said, "We've moved beyond the paradigm of single modality treatment for Barrett's esophagus." And I'm going to extrapolate from my talk on that by saying it's not a failure if we have to use 2 or 3 different ways to get somebody to CRIM. It means that somebody's particular disease is the kind that either isn't responding well to one type or is complex enough that we've got to put a couple of pieces together to get them to the goal. And so I want to leave that with you as we go into the next segment of the talk and talk a little bit more about spray cryotherapy. Spray cryotherapy uses liquid nitrogen. Now, the CO2 one is no longer available, although you'll see some of the studies quoted on that in the literature and in some of the meta-analyses. But liquid nitrogen is much colder, minus 196 centigrade. It's passed through a catheter that's advanced through the working channel of the endoscope, and it basically freezes the bejesus. See, I told you we're going to have a religious revival out of the area that you're aiming at, about a 3-centimeter long segment, about up to hemicircumferential in the esophagus. You can treat through stents, as was shown through some data from Moffitt in Tampa, and it does not require a flat surface to treat. So if you've got something that is scarred, that is really tortuous because of a large hiatal hernia or paraesophageal hernia, and you've got to get the disease out of there, this is an opportunity to bring something new into the toolkit. And in addition, it can be done while you're on blood thinners. It doesn't require the scraping of the mucosal layer that RFA does in between ablations, and that means that you can keep your patients on blood thinners with a minimal risk of excessive bleeding. And the depth of injury is much deeper, as Alfonso Ribeiro from Miami showed us. We can get much further down than that RFA depth that I showed you on the previous slide, all the way down to the adventitia if you really dial up the amount of time that you treat and freeze each site. And so for patients who've had particularly nasty nodular disease that you've finally been able to flatten out, where you didn't see any invasive disease, but you're worried that this is more angry stuff, this might be something that you want to think about using. Again, it also opens up the door for patients where you need to palliate or where surgery or chemoradiotherapy maybe aren't preferred options for the treating physician or the patient. You can jump in, utilize this, and open up a door for them for even potential to be cured of early cancers. But let's talk about it in the context of this discussion, which is we're not able to get to CRIM yet. What do we do? This is a very nice article from Samgupta that's now almost 4 years old, where a number of dysplastic Barrett's patients have been treated with RFA, kind of reached a wall, didn't get there, and about a third of them were able to get to complete eradication of all intestinal metaplasia, and the vast majority of them were able to get rid of all their dysplasia using salvaged liquid nitrogen spray cryotherapy on top of the RFA and switching out of RFA to the liquid nitrogen when that wall was hit. There have been some other studies that were done. There's a multi-center study with, again, another 18 patients at 2 high-volume Barrett centers, one being Rochester, where the median pre-dysplastic length was 8 centimeters. Of those 18 patients, none of them were able to get to CRIM. They switched to liquid nitrogen, and 50% were able to get rid of all Barrett, 72% got rid of all dysplasia. And then there's a nice meta-analysis that came out from Visrodia et al. That showed, again, very similar numbers, about 3/4 being able to get rid of dysplasia and about half being able to get rid of all Barrett's. Pretty good for somebody that was using the workhorse and wasn't able to get over the goal line. So I just want to build real quickly on what Felice was saying and just show you that SCT is also a primary option that you can use in addition to RFA in some of those circumstances, certainly that I just mentioned to you, where perhaps the anatomy, the patient's condition, their comorbidities, and their medications might preclude you from safely, effectively, or efficiently using radiofrequency ablation. And the numbers are pretty darn good for this technique as well. So, you know, if you have this in your wheelhouse, it doesn't have to be just a salvage therapy. It's something that's worth considering in a primary context as well. And quite frankly, works very well, but so does RFA. And if you use them both, that's great. You just have more ways you can help your patients. There's some other great options that are out there as well. Of course, we can use APC and multipolar electrocautery for touch-ups. Really best for use for lesions that are 1 centimeter or less when you're pretty sure that it's just refractory disease and nothing that's going deeper in, because again, you're not able to control the depth of treatment the way that you can with RFA, or get the extent of treatment down into the deep esophageal wall like you can with cryo, spray cryo. Nitrous oxide cryo balloon is something I've also used. A number of us in the room here, I'm sure, have used it for both primary and for salvage treatment. There unfortunately isn't great data out on it yet, but certainly anecdotally, there have been some very nice reports of being able to pick up on disease that was not moving forward. And again, both primary and secondary uses for this balloon as well. It's undergoing a technological reboot right now, but should be reintroduced shortly with some new features that will make it even more user-friendly. And then, of course, endoscopic resection, and I would add on from what Felice was saying that ESD is also something that we can start to think about, though I agree that the risk of lymphovascular invasion is a real problem when you start to say, well, how deep can we go and get something out and get somebody to cure?
Okay, so let's talk about a couple other reasons why ablation might fail. Certainly incompletely controlled reflux is really, really important, and Felice touched on that before. Again, I would add both acid and non-acid reflux can cause problems. And I would just point you to the third bullet here, which is that comorbidities like gastroparesis or underlying esophageal dysmotility that exacerbate the GERD or even just bring it out from hiding are really important. And I've had a number of patients who did not get to CRIM, went in a couple of times and saw some food in the stomach, did a gastric emptying scan, found out they had delayed gastroparesis, or delayed gastric emptying, put them on a prokinetic, and we were able to get them to GERD, and then ultimately sent them off for a fundoplication and pyloromyotomy together, and they've done beautifully. And again, remember that the inability to touch directly when you're using RFA or to get to a lesion because of an anatomic abnormality, particularly those large hernias, is something that can create a lot of problems in getting somebody there, but also surveying them and making sure that you didn't miss an area that you should have been biopsying just because you didn't see it. And again, make sure you keep your patients on a schedule. I use every 3 months. Some people are a little more aggressive and go every 2 months. I found that a number of patients never healed their erosive esophagitis by that point, or the ulcers from the treatment site, and I've had to bring them back 3-4 weeks later. When you see that happen with one of your patients, consider adding the liquid sucralfate to their armamentarium. That seems to help. Okay, so what can and should we do? I'm going to use this to wrap up very quickly with this part of the talk and then go to our next part. Standardize your terminology regarding lack of efficacy and inability to completely eradicate Barrett's. What does failure really mean? We need as a society to be thinking about that. We need to make sure our patients are getting adequate suppression of their reflux, certainly the acid component as best as we can, and the overall reflux with lifestyle and dietary modifications, particularly during treatment so that they grow back as neosquamous. We want to work to endorse optimal use of each these techniques, and we can do that hand in hand with our industry partners. And we need to think about developing an algorithm to help people to know what to do when they're not making forward progress, and also defining what adequate progress in ablation really means. And we need to think about employing those Barrett Centers of Excellence designations like Felice was talking about. So let's move very quickly to finish up and talk about the recurrence piece. Well, we know that people recur. And the fact is it's about 20 to 30% in most of the studies that we see. This is from the RFA registry. You can see about 75 to 80% of patients remain in remission, but that means 20 to 25% do not. And here's the best study that we have on the spray cryotherapy side from Bruce Greenwald's group in Maryland, again showing very similar numbers. And looking out at the 5-year data, 82% at 3 years, 75% at 5 years, again pretty similar to what we see with RFA. And the recurrence, you know, this is a really nice study that came out this year in gut from Sammy. I want to show you that we're seeing a stepladder here. We're not seeing a peak at 1 or 2 years and then a plateau. The recurrence keeps coming and coming, and this is why, as Felice said, this is really a commitment. This is not it's not an absolute cure. And Shri is right. We can cure it, but then we have to keep it cured, and that's a piece that I think a lot of providers and especially a lot of patients don't really understand. If you look where that recurrence is coming from, this is from the North Carolina group. They showed their 32 patients who had recurrence after documented CRIM, and it's very, very interesting that all but 3 of the 29 patients that had recurrence who had a long segment of disease recurred within 1 centimeter of the EG junction. That is clearly the hot zone. It's why we need to ablate that area really, really well. And as you can see, 40% of those recurrences were found on a random biopsy only. They got very lucky and threw the dart in the right spot, but it means that we've got an opportunity to do more and to do better. We can't rush our exam. I cannot emphasize that. You've heard that. I told you this is a revival. The word of the revival today is take your time, right? You got to pay attention to these patients, and we've got to do that when we're looking both after ablation as well as before ablation. And we need to think about enhancing how we sample the tissue, both optically and physically. Right? We need to think about that particularly in patients who are at higher risk for recurrence from the studies that have come out. The more advanced the dysplasia was before treatment, the longer the segment was, the older the patient, the presence of the hiatal hernia and the presence of a tobacco history all increase the chance that that Barrett's is coming back and they're going to be part of that 20 to 30%. We can use the Watts brush that Sri mentioned to before, and I just want to show you 2 studies of how this technique that creates a 3D reconstructed sample using artificial intelligence from 100,000 cells and cell clusters that are put on each brush. We're able to get these 3D reconstructions in A in addition to the cell block with an H&E stain in B and immunohistochemical stains in C to guide us. And this is a study that Vivek Kaul and I did for 208 cases from our institutions a couple of years ago in the post-ablation setting. Completely non-visible, normal-looking esophagus, C0, M0 after ablation. And we picked up an additional 61.5% more Barrett's and 57.1% more dysplasia, with very good numbers needed to treat. And we've got, this is, I guess, a little advertisement for what's coming out of DDW for us this year. We've now got it up to 913 cases from multiple sites, where we're seeing 79% more intestinal metaplasia diagnosed when Watts is added to the brush, and 224% more dysplasia when there's been a prior Barrett's ablation. And we're separating that out by endoscopic findings, and we'll have that for you on a poster in May in San Diego, with the number needed to test down below 5 to find residual or recurrent intestinal metaplasia, and below 25 to find dysplasia. So we can also use volumetric laser endomicroscopy, or VLE. This is the 9-point system you've probably seen in the hall next door, which uses a laser to take pictures of the esophageal wall down to a resolution of 7 microns and a depth of 3 millimeters. That gives us something that a lot of other techniques don't give us, and that is the ability to see below the mucosal surface. And when we're taking our really good look in our post-ablation setting, we still can only see the top layer, and we can't see into the wall. And being able to use something like this to identify buried disease when it doesn't look like this nice normal neosquamous epithelium, it looks more like this, and we see these little bubbles in the wall that are indicative of neoplasia. We've got multiple published case studies of residual or recurrent adenocarcinoma of the esophagus that was resected after VLE found a suspicious looking area, but there were no visual abnormalities on the endoscopic exam. This one coming out of the Mayo Group in Rochester, Minnesota. This one coming from Jacques Bergman's group in Amsterdam. Another one that's been published from the group in Chicago. Right? So we've looked at this stuff as well in the setting of a VLE registry of 1,000 patients at 18 sites across the country, with very normal Barrett's cohort looking like demographics. And basically what we found is if you did an optical scan in the post-ablation setting and you didn't see any abnormalities on white light, there was no neoplasia on the, and the OCT was also negative. There was no neoplasia that was found on the biopsies as well. We've really got no established guidelines right now for what we should be doing post-ablation. Right now it's sort of every 3 months for a year, maybe a little bit less than every year for your high grades, and then maybe we can forget it, maybe we can't. Felice says no, I agree no, but other people say yes. What do we do with this? We're the experts. This room is the people who really pay the most attention to this, and everybody's looking to us for guidance and to our societies for guidance, and we're not giving any. So we need to figure this out. We need to figure out not only what are the right intervals for surveillance, but can we use these adjunctive tools maybe to increase the intervals between surveillance times so that we don't have to be bringing these patients back so much and using up so many endoscopic resources. So putting it all together in the setting of the post-ablation CRIM patients, take the time to look, focus on the EGJ as the hot zone, right? Consider using augmented tissue sampling, actively consider anti-reflux surgery for your patients after they've gotten to CRIM. Don't rush and don't over-endoscope the patients. Follow the best guidance we have right now, but understand it may lengthen further as we go. And then let's think about ways that we can move this field forward together. So final disclosure, as the original board member and now secretary of the AFS, I am so incredibly excited about everything that we've done so far, and your being here really has fulfilled a dream of all of us who got together at the very beginning last year and started putting this together, and we look forward to seeing you at future events. And as the secretary, I'm going to take my prerogative to announce our new mascot. This is Lucy Goosey. She is the new mascot for the AFS. All right, thank you all.